This is A&P Live Studio. I am your host. As a registered nurse and anatomy and physiology instructor for advanced level healthcare professionals, I've had the chance to see just how beautifully complex our body's systems are, and what happens when communication breaks down.
And today, we're going to explore a really fascinating condition called myasthenia gravis. It's an autoimmune disorder that zeroes in on one of the most critical communication points in our entire body, that tiny, tiny gap where a nerve tells a muscle what to do.
So here's our roadmap. We'll start with a patient story to put a human face on this. Then we'll dive into how that nerve-to-muscle signal is supposed to work before we look at how the immune system messes it all up. After that, we'll connect the dots to the symptoms, how it's diagnosed, and finally, some of the really incredible ways we're learning to fix this broken connection.
To really get a feel for this condition, let's start where it always starts for us in healthcare, with a patient.
This is Ania. She's 28, and she's come in because she's experiencing something much more than just being tired from work. She's having double vision and this deep, overwhelming fatigue that just gets worse and worse as the day goes on. And her story is really important, because myasthenia gravis often presents earlier in life for African American women, making her case a really classic example of what to look for.
So to figure out what's happening with Anya, we've got to review the normal physiology first. The entire problem in myasthenia gravis is happening at a very specific microscopic location, the neuromuscular junction.
Looking at the big picture, it all begins right here. You have a motor neuron reaching out with its axon to touch a skeletal muscle fiber. This is the physical bridge that turns a command from your brain into an actual physical movement. It's an incredibly precise system where a simple thought becomes a real-world action.
Now let's zoom in, way in, to where the magic happens. Here at the neuromuscular junction, you can see the nerve terminal is just packed with these little bubbles, or vesicles, and each one is loaded with a neurotransmitter called acetylcholine, or ACH for short. And across that tiny gap, the synaptic cleft, the muscle fiber surface is all folded up. This is brilliant because it massively increases the surface area, giving tons of real estate to pack in acetylcholine receptors. This structure is absolutely key for a fast, reliable signal.
So how does that signal actually jump the gap? It's a super fast 5-step dance. An electrical signal, the action potential, zips down the nerve. This jolt of electricity opens up calcium channels and calcium rushes in. That influx of calcium is the trigger that tells the vesicles to dump their acetylcholine into the cleft. The ACH then floats across and locks into its receptors on the muscle side. This opens up ion channels, creates a new electrical signal in the muscle, and boom, you get a muscle contraction. Now, what's really important is that the system has a safety factor. It always releases way more acetylcholine than it needs, just to guarantee the signal gets through every single time. Keep that safety factor in mind. It becomes the whole story in myasthenia gravis.
So, that's how it's supposed to work. In myasthenia gravis, this elegant system becomes a target. It's a case of friendly fire, where the body's own immune system gets confused and launches an attack on this vital junction.
What the immune system does is create these things called autoantibodies, and they start targeting key proteins at the junction. The most common target in about 85% of people is the acetylcholine receptor itself. For others, the antibodies go after helper proteins, like MuSK or LRP4, which are really important for organizing all those receptors. And then there's a group of patients we call seronegative. We can't actually find any of these common antibodies in their blood, but all the signs point to an autoimmune attack, which just means there are probably other rogue antibodies we haven't identified yet.
And this image just shows the devastation perfectly. On the left, you see a healthy junction, deep folds, tons of receptors, a strong connection. On the right, well, that's a myasthenic junction. The number of available receptors has been slashed, and those beautiful folds have been flattened and simplified. That safety factor we talked about, it's completely gone.
So how are the antibodies doing all this damage? Well, they've got a three-pronged attack. First, they can just physically block the receptor so acetylcholine can't bind. Second, they can link up receptors, which signals the cell to basically gobble them up and destroy them faster than they can be replaced. But the third mechanism is the most destructive. It's called complement activation. Here, the antibodies kick off a chain reaction that forms something called a membrane attack complex, or MAC, which literally drills holes into the muscle membrane, causing all-out destruction.
Okay, so let's connect all this molecular chaos back to our patient, Ania. What does it actually look and feel like when that signal from nerve to muscle starts to fizzle out?
The absolute classic sign of MG is fatigable weakness. It's a weakness that gets worse the more you use a muscle. For Ania, this is showing up in the muscles that control her eyes, causing her eyelids to droop, that's ptosis,
and giving her double vision, or diplopia. But it can also hit the bulbar muscles in her face and throat, making it hard to swallow, chew, or even speak clearly. And it can cause weakness in her arms and legs, and, most dangerously, in the muscle she needs to breathe, like her diaphragm.
And that brings us to the most feared complication, a myasthenic crisis. This is a life-threatening medical emergency. It's when the respiratory muscles become so weak that the patient simply can't breathe effectively on their own. This requires immediate hospitalization and often mechanical ventilation to support their breathing and keep their cardiovascular system going.
So how do we prove that this is what's really happening to someone like Ania? The diagnosis is like putting together a puzzle, using a few really important pieces of evidence.
We have a whole toolkit for this. Blood tests are key to hunt for those specific autoantibodies. A thorough neurological exam can actually bring out that fatigable weakness, like asking a patient to look up for a minute and watching to see if their eyelids start to droop. Then there are electrophysiological tests, which are really cool. We repeatedly stimulate a nerve and measure the muscle's response. In MG, that response gets weaker and weaker with each zap, which is the classic sign of that eroded safety factor. And finally, because the thymus gland, part of our lymphatic system, is often the culprit behind producing these autoantibodies, we'll get a CT or MRI of the chest to see what it's up to.
Once we have that diagnosis, the goal is pretty straightforward. We need to restore that connection. And the beautiful thing about the treatments is how logically they target the different parts of the problem.
The strategies fall into four main buckets. First, we can just treat the symptoms. We use drugs that stop the breakdown of acetylcholine, which basically floods the synapse and gives the ACH a better chance of finding a working receptor. Second, we can use general immunosuppressants, like corticosteroids, to just tell the entire immune system to calm down. Third, and this is where things get really exciting, are new biologic therapies that are super targeted. And fourth, for many patients, surgically removing the thymus gland can make a huge difference. Let's look at one of these new biologics because they are a real game changer. Our bodies have a receptor called FcRn, and its job is to rescue our IgG antibodies from being destroyed so they stick around longer. Well, these new drugs block that receptor. This means the bad autoantibodies causing all the trouble don't get recycled. They just get sent straight to the garbage disposal. This quickly and dramatically lowers their levels in the blood. It's an incredibly smart way to take out the problem.
The other really exciting class of biologics are the complement inhibitors. Remember that destructive MAC complex that drills holes in the muscle? Well, these drugs act like a shield. They jump into that complement chain reaction and stop it in its tracks, which prevents the MAC from ever even forming. This directly protects the neuromuscular junction from one of the nastiest parts of the immune attack.
So, to wrap it all up, we start with a normal, healthy signal transmission. Then, in myasthenia gravis, autoantibodies attack that system, destroying the safety margin and causing the classic sign of fatigable weakness. And our treatment strategies flow right from that understanding. We can either try to boost the failing signal, or, even better, we can stop the immune system's attack right at its source.
Myasthenia gravis is such a powerful example of how a very specific molecular problem can cause such profound weakness. But it's also a story of hope, as our growing understanding allows us to develop targeted therapies that can truly restore that connection for patients like Ania. I'll see you in the next session. Stay patho-curious.
This video is for educational purposes only and is not intended as medical advice, diagnosis, or a substitute for professional healthcare decisions.